Hello everyone, I welcome you to another video lecture. Today's topic is minimal change disease. So, minimal change disease is a major cause of a nephrotic syndrome in children, approximately 90%, and in a minority of adults, approximately 10%. Why it happens? What's the pathogenesis behind minimal change disease? So, the underlying cause of MCD is unclear. Accumulating evidence suggests that systemic T cell dysfunction is the main pathology behind, which results in production of a glomerular permeability factor, and this circulating factor directly affects the glomerular capillary wall, resulting in marked proteinuria and food process effacement. And the food process effacement is the main pathognomic feature of minimal change disease, as a result of which there is a polyanion loss. As you can appreciate in this picture, this is a normal glomerular capillary, and this is the minimal change disease glomerulopathy. The food process damaged over here, and there is a food process effacement, as a result of which polyanion loss and selective proteinuria of intermediate size protein including albumin and transferrin happens. There is a very important point when considering a minimal change disease and primary focal segmental glomerulosclerosis. These are these diseases are both an excellent example of pathogenic mechanisms that predominantly affects the podocytes. So this is the disease which is especially affecting podocytes. What is an etiology behind that? So the most of the cases of MCD are idiopathic and are not clearly associated with any underlying disease or event. But there are a variety of secondary causes like drugs, including NSAIDs, rifampicins, some neoplasms like Hodgkin's lymphoma, or infectious mononucleosis. Coming towards the clinical feature, in most patients, MCD is characterized by a sudden onset over days to weeks, or two of the signs and symptoms of nephrotic syndrome, often following an upper respiratory tract or systemic infection. But typically the sudden onset of nephrotic syndrome in MCD is in contrast to a gradual increase in proteinuria over weeks to months in most other causes of the nephrotic syndrome. So nephrotic syndrome, which is gonna come as a proteinuria with intermediate size proteinuria including albumin and transferrin. Coming towards the diagnosis of MCD should be suspected in any of the individual who present with signs and symptoms of nephrotic syndrome, especially if the onset is relatively acute, like from over days to week rather than months to year. Kidney biopsy is required to establish a diagnosis of minimal change disease, especially in adults, and to exclude other causes of nephrotic syndrome. In children, you can start with the treatment, but as we are doing exam preparation, so in adult, the renal biopsy is very important, and in the renal biopsy, the pathognomic feature is fusion of podocyte. Coming towards a treatment, so the treatment, most important factor in the treatment of minimal change disease is corticosteroids. Complete remission can happen in 80 to 95% of adults with the steroids, but if anyhow the corticosteroids are contraindicated or not tolerated by a patient, then glucocorticosteroid sparing agents like calciurin inhibitors, cyclosporin, tacrolimus, cyclophosphamide, mycophenolate can be used. Then there's a general supportive measures like a sodium restriction, blood pressure control with ACE inhibitors can also be done. Approximately 50 to 75% of adults will have a relapse. and frequent relapses can occur in 10 to 25% of the cases, and 25 to 30% of the patients might be dependent on the glucocorticosteroids. Let's solve one BCQ and see how we have learned. So, in this scenario, the question is, what is the most appropriate initial diagnostic step? So, what we should be doing? A 35 years old female presents with a 2-month history of a generalized edema, foamy urine, and fatigue. She has no significant medical history. On examination, she has a significant bilateral lower extremity edema, and the labs are as follow: hemoglobin, white cell counts all right, platelets all right, blood film there's no significant findings, sodium all right, potassium all right, urea is raised 24, creatinine zero point 0.8, total bilirubin zero point 0.9, direct bilirubin zero point 0.4, indirect 0.5, and there's a massive proteinuria and no hematuria. So it's a young female with massive proteinuria. The options are kidney biopsy to confirm the diagnosis, high dose corticosteroids to initiate a treatment, further evaluation for autoimmune causes, genetic testing for hereditary kidney disorders, or follow up and do nothing. So, the answer is a kidney biopsy to confirm the diagnosis. As we have discussed earlier, in the cases of adults, we have to do a renal biopsy to confirm the diagnosis, and the pathognomic feature is a fusion of podocytes. Explanation with while this patients present with symptoms consistent with nephrotic syndrome, it is crucial to rule out other potential causes of proteinuria and edema. In adult, minimal change disease accounts for only a portion of nephrotic syndrome cases. Kidney biopsy is the gold standard for confirming the diagnosis and differentiating it from other glomerular diseases. This allows for a precise treatment decision tailored to the underlying condition. While high dose oral corticosteroids may be considered once MCDs confirm, initiating treatment before biopsy may not be advisable due to diverse causes of nephrotic syndrome in children. Thank you.